All right, let's talk a little bit about injection techniques. I'm going to really slam through this. I just want to make sure that before we sit down, and this is none of this stuff, I won't say none of this. If there's stuff from this that's going to be on the exam, I'll be very careful to tell you, I might ask a question about this, etc. Right? Most of what I want you to focus on is the stuff about contrast media. This is largely just so that you have had some training in thinking about IV access, so that if the opportunity comes up in your clinical site, you can do it prior to Mr. Wolf introducing it in procedures. Okay? And also make sure that we all have some common knowledge. So the very first thing we want to think about anytime we're doing IV access is standard precautions. So the CDC, standard precautions apply to blood, all body fluids, secretions, exertions, excretions, non-intact skin, mucous membranes, and also hair. Hair's not in there, but hair is just as gross to me as blood, right? It's like when my wife's food, hair winds up in the food, it's like you just bled all over the thing, you know? It grosses me out. So we're going to apply a aseptic technique, which means that we're going to clean our surfaces. This is not a sterile technique, it's aseptic, it means clean. We're going to employ frequent hand washing, choose appropriate personal protective equipment, whether that's a glove, gown, or mask, given different types of patients that we come into contact with. And I think it's very, very smart prior to doing an IV to get your supplies all together in one place. Because what happens if you're halfway through the IV and the patient's blood's going all over the place and you don't have a little screwy-on cap to put on the thing, that's a problem, right? So generally what I do is I almost make like a little sterile field, an area that I've cleaned off. It's not quite a sterile field, but I've cleaned off this area, and I've got everything, all my supplies lined up. I've pulled off a few of my tapes. I've got my Heplock or whatever thing that I'm going to use to stop the bleeding. I've got that opened already. I've got my IV access needle and everything opened up and ready to go, right? So that I'm not scrambling to grab things while the patient's bleeding all over the place and then I look like a dork, right? Plus there's blood everywhere. And thinking about sites, if we're talking about for mechanical injection, and that means using a robot to inject IV contrast into a patient. We do that in CT. That's a big part of how CT works. We use these intelligent mechanisms that can sense people's blood pressure to do the injection for us. And it's like they do the timing and everything. When we're thinking about that, we have to be very careful, right? So in general, the places that nurses like to access are down here, these radial arteries on the back of the hand. Nurses like that because they can see the IV, even if the person's draped for surgery, they can see where the IV is at. They have other reasons why they like it as well. They like to be able to feel how the injection is going and things like that, especially if they're injecting really small amounts of something like morphine. They want to be able to sense, okay, yes, it definitely went into the vein. I did not just extravasate that little tiny injection of morphine, right? We don't really like this area, though. What we like are these brachial arteries, and we sometimes talk about them as antecubital access points, areas in front of the elbow. That's all antecubital means. It means in front of the elbow. So the brachial artery is our artery of choice, and it has these different little branches right here. So we need to be aware that just below the elbow it has a fork to it and the blood is flowing in this direction. So as we're palpating around on the patient, we're going to be looking, okay, where is the fork? Okay, I want to go somewhere probably north of that, right? Now we need to be thinking, if we're going to inject IV contrast into this area moves, right? So if I've got my IV south of this area and the patient does this, what just happened? I just kinked the vein. I just closed off the IV basically. So now if I'm going to use a power injector to inject through that, I'm running a real risk for extravasation, right? Interestingly enough, the exact same thing can happen, especially in CT, if I ask the patient to bring their arms up. Now I just potentially kinked it up here, one severe IV contrast extravasation that I've seen. Came in this little tiny old lady. I said, bring your arms up. She felt fine the entire injection, but I kinked the vein here, and it blew down in here. So I never even I was feeling her arm the whole time. The injection went great. We do the scan, there's no contrast in her chest. We scan her arm, it's all right here. I felt terrible. So, but the point here is that these access points that we like are generally the antecubital vein on the right side. Right? So if there's existing vascular access, we can use that, but we want to be very careful about how we use it and everything. So if they have a venous catheter already in place, if they have an IV already in place, we will test it with some saline. Saline is not considered a medication. It's considered basically preliminary work to doing the IV contrast injection. And so we'll get a little 10 milliliter syringe of saline, clean the access off, and then pull back on the syringe to see if there's flush, and then inject, and feel for it injecting. It'll feel like water running through a garden hose, right? That's what we're feeling for, is that kind of rumbling feeling of the fluids being introduced to the vein. We can use PICC lines. These are access points that are tunneled up through the artery to just north of the heart. And these are done by specially trained nurses. So y'all have probably been out on portables if you've worked at a hospital for any length of time to do a PICC line, to verify PICC line placement. And they're looking for the little radio opaque markers on the PICC line to make sure, okay, yeah, that's in a good place. They'll use PICC lines because they're stable ways to introduce medications to the patient's body. So we use them quite a bit for chemo or other types of like serious antibiotics and stuff like that. A tunneled CVC or port. Has anyone yet been to OR to see port access stuff? Or has anyone seen a cancer patient who has a little bulge right here on their chest? That is a port. Those are placed surgically, and they can be accessed with a kind of a crooked needle like this that's hooked into the skin, right? A lot of times they'll numb up the skin or something prior to access. We can use those if they have a special type of production. Generally, the ones that are triangle shaped are called power ports. The patient should have a card saying that this is a power port, we can inject contrast on it. Okay? If we have any doubts about it, don't inject. And that means even for an IV that I started myself. If I don't think that this is a good IV, if I question it, I'm just not gonna inject. I'll try to get a different access. There are phases of tissue enhancement. So this is the name of the game for CT, but we also need to think about this if we're doing like an IVP or something like that. There's the bolus phase, which is largely when the contrast is in the arterial system. We'll call it the bolus phase. And bolus just refers to like a solid amount of contrast is kind of unified as it's traveling through the vascular system. That's the way that we think about bolus. Nurses will talk about bolusing the patient or something like that. They mean we're going to give a unified injection to the patient. That's the way that we're talking about bolus too. So we're using the term the exact same way. But this bolus phase is when the majority of the contrast is in the arterial system. Then there's what we call a non-equilibrium phase. Now the contrast is entered into both the venous, so there's arterial contrast as well as venous contrast. So most CT exams are done in this non-equilibrium phase, and we'll call it a venous phase of contrast sometimes, where the contrast is primarily in the veins. And then following that, there's an equilibrium phase, where basically the IV contrast is useless to us because it's been spread throughout the entire body, and it's just kind of equally throughout all parts. The reason that we did contrast was to make a difference. We wanted something to show up more clearly, and so we needed it to look more different. Equilibrium means it's all the same, right? So this is actually not helpful to us, that there's this phase where the contrast has just been evenly distributed throughout the body. Now, most of the time, if we're doing IVPs or things like that, that's the most common way that you'll be using IV contrast as an X-ray tech is for an IVP. Following this equilibrium phase, there will be the phase of clearance. So what we would call like a renal phase or a bladder phase, where the contrast is now being picked up by the kidneys and excreted down the ureters into the bladder. So that renal phase is what we're shooting for with an IVP. So when we're doing these kinds of X-ray type exams, we will be waiting some time before we do the actual pictures. These phases are related to time from the point of injection. So injection happens. After a short period of time, we're in the bolus phase. A little bit longer, we're in this non-equilibrium. Then as we get further out from the contrast injection, we go into an equilibrium phase. And then about 10 minutes, or 5 minutes out, we start to see it in the kidneys. About 5 minutes out, we'll see it in the kidneys. About 10 minutes out, it would start to be in the bladder. So the body's picking it up. So there are different bolusing techniques. The most common one that we use in X-ray is a hand bolus, where we just hand inject the amount of contrast needed for the examination. We do that also for pediatric exams. We'll hand inject. We'll figure out what the patient's weight is, and we'll actually hand inject in order to prevent extravasation. For CT examination, we'll use mechanical injection, which means we have like a little robot that we'll program, and it will actually do the injection for us. Extravasation is the #1 risk related to IV injection next to infection. So we can get rid of infection by practicing appropriate aseptic technique. The extravasation, here's some ways to prevent it. We want to use a larger gauge IV if at all possible, so 18 or 20 gauge. IV gauging is just like gauging for piercing needles. As the number goes down, the size goes up. So if you look at a 16 gauge needle, that thing is huge, right? In general, we're fine with an 18 to 20 gauge peripheral IV site. We want to monitor it. We want to watch things. We want to warm the contrast media, because we said that can do what? Yes, reduce viscosity. So that would help with extravasation as well. And just using the low osmolality contrast media will also prevent extravasation. If there is an extravasation that occurs of a sizable amount of contrast, there's a lot of different things, but the literature disagrees a little bit on it. My findings have largely been that we should apply heat for about the first 6 hours and then apply cold compresses to the area. Occasionally, if it's severe enough, they may inject a steroid into the area to cause reuptake, or surgical drainage, where they actually excise the area and drain it. Air embolism is another potential risk related to this, and this is largely related to mechanical injection. So the way these mechanical injectors work is they have a syringe that's pretty large, and you plug it into this little plunger system. So now the plunger system works off of basically a computer program to do the injection. It pushes the injection. I'm responsible, though, for loading up the contrast into that syringe, right? If, for some reason, while I'm loading the contrast, I am not paying attention, and rather than loading contrast, I load that syringe with air, and we inject air into the patient, this can kill them, right? If we introduce air into the venous system. Even tiny air bubbles. So one of the reasons that you see in the TV shows, the nurses always thump the syringe or whatever, or they squirt a little bit of the solution out of the syringe prior to doing an injection. What are they doing? They're clearing the air bubbles to prevent air embolism, right? Another thing, I mean, you've probably also seen this on one of those weird spy movies where they actually kill someone with an air embolism. Yes, you can kill a patient with an air embolism or cause permanent neurological damage. Because it would work just like a blood clot in the brain, right? when that air bubble hits the brain, it would block the flow of blood through that brain blood volume thing. The blood would not be getting past that anymore. So if you don't have blood flow to the brain, that's what we're talking about when we talk about a stroke. So in general, if we're going to use a mechanical injector, and anytime we're doing contrast, we're going to take caution to make sure that there's no air in the system. The way that we generally indicate that in CT is we point the injector towards the ground when it is ready to go. That's kind of the universal sign that I've checked the system, I've made sure there's no air in the system, and it's ready to go. So if another tech loaded it for me, and I come in with the patient, and I'm hooking the patient up, if I see an injector pointed up, I think, oh wait, it's not ready. If I see it pointed down, I think, let's go. So these contrasts, as we're introducing contrast into the system, we are going to have to think about a number of different things. And this is really just a kind of preview of CT type stuff. We think about the amount of contrast we are injecting. And given the amount, we think about how long it will take to do that injection based on how quickly we do the injection, right? So different examinations have different injection rates, and that will also vary the flow duration, the amount of time the actual injection takes as it relates to the amount of stuff that we give the patient. So all of those are things that we think about. And that is it.